in the management of ALK positive metastatic non-small cell lung cancer. Next slide. So we all know that ALK inhibitors have come of age as far as the treatment of lung cancer is concerned, and as such, lung cancer incidence is likely to increase in India, and it is following a very dreadful trajectory as far as the incidence is concerned. So is the mortality. Next slide. And still, I think we have not made much headway as far as early detection of lung cancer is concerned. We don't have any lung cancer screening program as exists in the Western world. And so we still have a very high mortality as far as lung cancer mortality is concerned. So most of the cases are detected in late stages. ALK rearrangement is present in about 7% of, and one of the most common after the EGFR mutation, and which is a targetable genomic change and makes them sensitized to ALK inhibitors. Next slide. The ballpark overall survival reaches almost about 7 years, and that's 81 months, and that's what is being produced from real world data, and that is quite reassuring and quite compelling as far as the use of ALK inhibitors are concerned in diagnosing non-small cell lung cancer with ALK mutation. Next slide. So typical clinical pathological features are minimal no smoking, adenocarcinomas, younger age, and lack of other mutations such as EGFR. Brain metastasis is fairly common, so it's very important and prudent to do a brain MRI upfront. And most of the ALK inhibitor studies include a brain MRI compulsorily. And the prevalence is about 7% in 5% in unselected, but in selected population, maybe around 7 to 8% also. Next slide. So this is the ALK inhibitor development timelines. It was detected in 2007. The first crizotinib, the first generation drug was launched in 2012 based on the profile studies. Then came the second generation, and that was usually after the failure of crizotinib, and then the first line usage of the second generation, and then came the third generation drug, blondrotinib, and then the first line usage of blondrotinib. Next slide. Next slide. Yeah, so these are the various the structures of various molecules, and we can see that there are subtle changes here and there, which makes them more CNS penetrable and also causes better efficacy and better efficacy against mutations. Next slide. So more activity, more potency, and better CNS activity. The profile 1001, which was the initial study, showed a remarkable overall response rate of 57% with a disease control rate of 87% in a pre-treated population with median progression-free survival of 9.7 months. Next slide. Then was the profile 1007 and 1014, which established crizotinib in the first-line treatment as when it was pitted against chemotherapy in the first-line treatment of ALK-positive non-small cell lung cancer patients. And the ballpark figure for progression-free survival was about 10 months or 11 months. Next slide. So there were various other trials of second generation, such as the ASCENT trial. ASCENT-4 was serotinib versus chemotherapy and not pitted against crizotinib, and that is one factor which one talks about serotinib not been pitted against crizotinib. But the progression-free survival is definitely better than what is achievable with crizotinib. Alectinib has been pitted against crizotinib in the ALEX trial, and the median progression-free survival was a whooping number of 34.8 months. And so was with brigatinib, which hit a progression-free survival of around 24 months. So all these drugs were performing much better than what crizotinib performed. So they found their usage in first line. Next slide. So almost replacing crizotinib practically. Blondrotinib was a third generation drug, and its activity in the brain and activity against acquired resistance to ALK inhibitors has been well established now. Next slide. So it has activity against most of the mutations such as the G1202R, the F1174L, and so on and so forth. Only the L196M is something which it is resistant to. And so these are important because there are a lot of mutations which can occur. And so it binds with a lot of affinity with ALK and has amazing CNS penetration. Next slide. So this is one paper from Tata Memorial, and which looks at the real world data and shows that lorlatinib does produce a remarkable response rate in a pre-treated population of about 50-60%. And with patient with brain metastasis, the response rate is around to the tune of 60%, which establishes that the drug has a very potent effect in the brain metastasis as in the systemic disease. Next slide. So it also depends on how do you sequence these drugs. So if you sequence these drugs with first line, then the second line, then the second generation, then the third generation, you're likely to encounter a lot of double mutations, including the more dreaded L1196M mutation, which is resistant to even lorlatinib. So it is important that the more efficacious drug is brought in early, because if you use a lot of sequencing strategies, which is something which has been argued upon, that one should sequence to get the best possible outcome. But the counter argument to that is that you're likely to encounter with more mutations, more tougher mutations, double mutations, triple mutations, and that is how you can lose out on the efficacy of the better drug in later lines. Next slide. So there can be triple mutations as highlighted over here, and which can make the third line usage of a more efficacious drug less efficacious. Next slide. So lorlatinib, as the lines of previous TKIs improve or keeps on increasing, the efficacy keeps on dropping of lorlatinib, and so is the median progression-free survival, and that is what is highlighted over. Next slide. So the rationale of upfront use of a pan-inhibitory agent is that you're not likely to encounter more resistance, and perhaps you're able to get better and increase your progression-free survival and give the best drug. Same is the concept with osimertinib in first line, because it has proven that the overall survival was better. And very similar on the same note, the lorlatinib also holds true. Next slide. So this was a CROWN study, and of course, the proof of the pudding is in eating. So this is the patient data and the clinical trial, the CROWN study, which was a 1:1 randomization between crizotinib and lorlatinib, 100 milligram OD versus 250 milligram BID, and the presence of metastasis, brain metastasis was allowed. There was stratification based on ethnicity. The median, the primary endpoint was progression-free survival assessed by the independent review committee. And then there was a PFS by the investigator, overall response rate, overall survival, quality of life, etc. Next slide. Next slide. So these are the patient dispositions, and so we can see that these are quite well matched between the two groups, and nothing very highlighting over here. Next slide. And about 26%, 25% patients had brain metastasis. So the primary endpoint was met, and the progression-free survival was not reached, but at a 12 months mark, it was 39% versus 78%, which was almost doubling of the progression-free survival. And the median in the lorlatinib was not reached, and the hazard ratio is 0.28. Next slide. Which is by far the best. And if you look at the PFS by the investigator, it was 0.21. The hazard ratio is even better. Next slide. And this is the first plot, which basically dictates that all subsets are equally getting benefited. As a matter of fact, those with brain metastasis are benefiting even more. Next slide. So overall response rates are in the tune of 76% better than crizotinib, and there are few CRs, and the overall disease control rate is also better. Progressive disease is by far similar between the two arms, that is around 5%. Next slide. So this is the intracranial efficacy, and if you look at the intracranial efficacy, it is remarkable with lorlatinib. So patients with measurable bone metastasis, brain metastasis had almost 82% response rate, which by far is better than the 72% response rate, which is in the systemic disease. So 82% response rate in brain metastasis with those with measurable brain metastasis is certainly very remarkable, and the median duration of response is not reached versus 10 months with crizotinib. Next slide. So intracranial time to progression by the independent review committee, you can see that it's almost a straight line with lorlatinib. There's hardly any dip in this Kaplan-Meier, and whereas crizotinib does keep failing as the time progresses. Next slide. This is overall survival, and we have a hazard ratio which favors lorlatinib, although not reached statistical significance because it's not yet mature. Next slide. So adverse events are I think we all understand these adverse events, and as far as the adverse events causing permanent discontinuation of drug was lesser with lorlatinib, not statistically significant, but it was lesser with lorlatinib, and it was not very different between the two drugs. Next slide. So these are the adverse events. We know that we got to use some form of statins whenever we are using lorlatinib because it does cause the hypercholesterolemia. Next slide. Quality of life was better with lorlatinib as compared to crizotinib. Next slide. So in conclusion, lorlatinib resulted in a significantly longer progression-free survival, significantly higher overall and intracranial responses, and as such, the intracranial responses was 82%, and with even complete responses which have been resisted. And the safety profile calls in that both are well-tolerated drugs, and these results support the use of lorlatinib as an effective first-line therapy for patients with advanced ALK-positive non-small cell lung cancer. Next slide. And if you compare with the other agents, the hazard ratio with lorlatinib seems to be the best. It stands at about 0.28. As far as the investigator assessed progression-free survival is concerned, it was 0.21, which seems to be very, very reconciling. Next slide. And if you compare, if we put this data into context of comparing lorlatinib with alectinib and brigatinib, although these are not head-to-head comparison, but it's likely to give a hazard ratio of 0.54 or 0.59 when pitted against brigatinib and alectinib respectively. And in case they are untreated and ALK inhibitor naive population, again, it is likely to give a better hazard ratio as compared to. So these are projected hazard ratios. Next slide. So these definitely fetch a category 1 indication. Lorlatinib, brigatinib, and alectinib fetch category 1 indication in the NCCN guidelines. Next slide. And even in the ESMO guidelines, it highlights as one of the preferred indications for the use of alectinib, ceritinib, and brigatinib. Next slide. So overall dose interruptions, as far as alectinib, brigatinib is concerned, it is lesser than the dose interruptions is lesser with lorlatinib, and overall discontinuation rate also seems to be slightly better with lorlatinib. So all in all, it seems to be a well-tolerated drug. Next slide. So this is the feasibility and challenges for sequencing, and of course this remains an open question, and these are various therapies and strategies which are getting evolved. Next slide. And the EML4 ALK, there is one variant where p53 co-mutation can coexist, and even in that population, lorlatinib is holding its gun well, and it's performing quite well even with variants and as well as TP53 co-mutation. Next slide. So overall survival curves are here to be seen, and yes, the ALX data seems to be slightly immature yet, but yes, the curves are separating, and it appears that lorlatinib is like as with longer follow-up, lorlatinib curves are likely to separate even further. Next slide. So I think we can skip this. Next slide. So this is the final slide, and the progression-free survival, which remains the hallmark for drug approvals. And I think lorlatinib has definitely fetched the highest progression-free survival with a very impressive hazard ratio of 0.28, which seems to be better than with any type of second-generation ALK inhibitor. Next slide. So, so this is my final concluding slide, that the results seem to favor lorlatinib over other ALK inhibitors, but one is free to sequence them, but sequencing may be fraught with more resistant population, which may make the third generation lorlatinib less effective in later lines of treatment. Next slide. With that, I thank you and over to the audience.